in integrating VASES into their own practices, a brief overview of kind of the rules of VASES, so to speak, and then some slides on how you might actually implement it into clinical practice. So, as we all know, flexible endoscopic evaluations of swallowing or FEES was originally published in 1988 by Dr. Susan Langmore and colleagues, and has really kind of exploded in terms of its clinical use since those 30 to 40 years. Oh my gosh. We know that it's a procedure where we use a flexible endoscope that goes through the nose to view the pharynx, larynx, and subglottis before, during, and after swallowing. Now, before I jump into the kind of diagnostic advantages and limitations of FEES, I like to kind of get always on the same page regarding some standardized terminology that we can use to think about the advantage and limitations of various other instruments as well. So in terms of standardized terminology, one thing that we oftentimes think about is swallowing physiology. And swallowing physiology, or rather just movements in general, can be described and evaluated according to kind of two larger types of parameters. We have kinematics and pressures. So kinematics, this is just a fancy term. It's used a lot in movement sciences and refers to the movement of structures without consideration to the forces behind those structures. So really just kind of like what we see in terms of movement. That's kinematics. It's used a lot in movement sciences. It's not just a speech pathology term. And so it can be applied to any sort of movement of speech, movement of breathing, movement of swallowing, movements of coughing. So we have respiratory kinematics, speech kinematics, swallowing kinematics. From there, we can break kinematics down into spatial and temporal. So spatial kinematics refers to where a structure is in space. That might be how far it moved. So if we talk about how far something moved from point A to point B, we'd call that maybe displacement kinematics or range of motion. And we can also think about things like peak position. So how far is something away relative to something else? Not how much did it move, but just like at its max displacement, how far was it away from various other structures? So those are both different forms of spatial kinematics. Then we have temporal kinematics, which refers to the onset of a movement, the offset, the duration of a movement, and even the sequencing of one movement relative to another. I think in the field of speech pathology, we very oftentimes at least talk a lot about spatial kinematics. I think it's kind of the way our brain has trained, right? So when we're talking about things like reduced base of tongue retraction, reduced UES opening, reduced pharyngeal constriction, like those are all spatial kinematics. But we can see that a big piece of this puzzle is also temporal kinematics. So when are these things moving? How long are they moving for? What is their sequencing like relative to other movements? And I think this is something that we oftentimes talk less about, probably having to do with our training. I also think it's hard to see a lot of temporal kinematics and knowing kind of objectively, oh, that looks like the PES isn't opening as long as it should. It's easier to see when there's an indentation, but to kind of see things frame by frame is a little bit more challenging. Another big piece to swallowing physiology is swallowing pressures. This is pretty self-explanatory, but just like we can think about kinematics, pressures can also be essentially dichotomized into thinking about the onset, offset, sequencing, and duration of various movements and the pressures behind them, and also the extent of them or the magnitude of them. So this, it's really kind of swallowing physiology that ultimately leads to the underlying outcome of swallowing. Swallowing physiology is what ultimately determines how functional the swallowing is. So functional swallowing outcomes is a term that's being used more frequently, and it's really meant to refer to bolus-related outcomes. And again, this is not just a swallowing specific term. When we think about movement sciences, any sort of movement that we have, certainly there's physiologic aspects to these movements like walking, but the point of movement is that it's goal oriented. It's got some sort of function behind it. So we don't measure walking just for the sake of measuring walking. We're doing it because we're trying to get from point A to point B. And so any movement, most movements that we have are goal-directed movements or functional movements. And so we want to think about what is the motor task trying to accomplish. That's where we're kind of distinguishing this with a different concept of functional swallowing outcomes. And so when we think about swallowing from kind of the basic standpoint, I'm trying to get foods from our mouth and into our stomach. We do it with kind of two considerations behind it. We want it to be both safe. So when something is not safe, we're said to have airway invasion, which is penetration and or aspiration. And then we also want to swallow efficiently. And so when things are inefficient, we might have impairments such as pharyngeal residue, especially if we're focused on kind of more the pharyngeal phase of swallowing. So the terms, I think, swallowing safety and efficiency, some people might agree with them, some people not, but they became a lot more popular since the development of Digest by Dr. Kate Hutchison, who's at MD Anderson in 2017, 2016, something like that. And so we kind of jumped on these terms as well to kind of continue with kind of helping to standardize these terms. So when looking at research that compares fees with video fluoroscopy, which for so long has been, and by some still are considered to be the gold standard, we can kind of compare the diagnostic advantages and limitations of fees if we are using something like fluoro as a gold standard or a reference standard. When we think about these diagnostic advantages and limitations of fees, we can look at two different kind of groups of literature. The first group of literature is kind of looking more at swallowing physiology, specifically kinematics, because neither fees nor fluoro look at pressures. So we can look at some of the research that's compared swallowing kinematics as seen on fees and fluoro. And the reality is that there's only a couple of studies out there at this time, and they're kind of dated. And I think it's in part because the findings behind these are not super surprising. One of the main studies, I think probably the best study out there, was completed by Dr. Jerry Logeman and colleagues in 1998. And what she did in this study was she and her colleagues examined the frequency with which various clinicians and researchers could identify 10 different swallowing kinematic events seen during both a simultaneous fees and fluoro. So when I say that, I'm saying a fluoro was on, and at the same time that the fluoro was on, a scope was in someone's nose looking at something. And then the raters looked at these kinematic events separately between both fees and fluoro. And what we're looking at here in this table, on the leftmost column, we have the various swallowing kinematic events. And then our subsequent columns is talking about the frequency with which this was seen on fees. So the numbers that we're looking at is the percentage of time that the kinematic event was seen on fees. And numbers, so I guess, so if a number is saying 0%, it's saying that that event was never seen on fees. It might have been seen on fluoro, but not on fees. If the number is, let's say, 95, it means that for 95% of the video clips, they were able to see it on fees. Furthermore, numbers that are black in this table are numbers that were seen more frequently on fluoro than on fees, and numbers that are red are numbers that are seen more frequently on fees than fluoro. And so what we're looking at in this table is that a lot of these numbers are black, indicating that the event was seen more frequently on fluoro than on fees. So this is not a good thing on fees if we're trying to look at swallowing kinematics. And a lot of those black ones are 0%. So they were never seen on fees. We do have some red numbers indicating that these events were seen more frequently on fees than on fluoro, but that you can see that even over half of these numbers, they're less than 50%. So for the majority of these kinematic events that are seen more frequently on fees than fluoro, they're still being seen less than 50% of the time by a group of clinicians and researchers. And so I think what I take away from this study and the couple of studies that are similar to this is that fees is not necessarily great at looking at swallowing kinematics. We can try to make inferences. We can try to make educated guesses on what we're seeing with fees based off of residue patterns. But as clinicians and as researchers, we definitely need to know that those are just inferences. They're just best guesses. I will say from a personal anecdote that when I was originally training and started off as a clinician for my first few years of clinical practice, I was at an institution where everyone got like fees and fluoro. It was a really wonderful institution, and resources were plentiful, which is not normally the case. And I thought I was very good at interpreting fees. I would have like huge sections in my impressions report, kind of describing what I thought was very smart inferences. And then I go do my PhD, my postdoc at an institution where we just had fees. They now have fluoro, but they didn't have fluoro when I was there. And we would be doing pieces on, lots of patients, and I'd be making what I thought were really educated inferences. And then we would have to go refer them out to do a fluoro, and then they come back and it is nothing like I expected. I mean, it's not like these people had a quick change in their function either. And so I think that was really kind of informative for me to kind of realize what type of confirmation bias I might have had in the past, thinking I was predicting something pretty well, when it's probably just because I saw the floor and I was like, oh yeah, that makes sense, that makes sense. And so that research plus that experience has really led me to kind of really pull away from talking about swelling kinematics in my report writing and in the types of things that I'm analyzing on fees. And if I do talk about kinematics, I make it very clear to the reader that is just a best guess at that. So then we can look at the other types of outcomes for swallowing when we're comparing fees and fluoro, right? We just talked about swelling physiology and kinematics, and now let's kind of shift to thinking about the rest of that framework, thinking about our functional swallowing outcomes. And here there's a lot more studies that have compared fees and fluoro, or really endoscopy and fluoro. So in the leftmost column, we're looking at studies that included rigid endoscopy, or what we sometimes called Cs, where a scope goes into their mouth after a swallow and has looked at residue patterns. In the middle column, we have non-simultaneous studies. So typically a fees was done, and then a couple of weeks later, or maybe a couple of days or hours later, a fluoro was done. Those are a list of studies there. And in the rightmost column, we have probably the strongest study design, which are simultaneous studies. So fees was in place, as well as the video fluoroscopy going on, and then outcome measures were compared. And when summarizing these studies, what we typically see is that typically there's good to excellent agreement between fees and fluoro. This is a good thing. This means that when, let's say, residue was seen on fees, residue was also seen on video fluoroscopy. Or if aspiration was seen on fees, then likely aspiration would have been seen on fluoro. This is good. This is what we want, right? If we're referring a patient for one exam and they get another exam a week later, we want to know that the change that we're seeing is because of a change in their function, not a change in how we're interpreting an instrumental assessment. That would not be good. So we want like perfect agreement, but we're never going to get that. So good to excellent agreement is great. But when there was disagreement, it looks as though fees typically has the edge, despite some of its limitations like endoscopic whiteout. Like despite some of the limitations that people always rightfully mention, fees still tends to be more sensitive than fluoro. So on the plus column, we're looking at outcome measures related to differential residue. These are the number of studies that identified that talked about them, penetration and aspiration. And in this bottom row, this is that fees was identifying events more frequently than video fluoroscopic swallow studies or modified barium swallow studies. And so when looking at residue, we see that 61% of the studies identified found that fees identified residue more frequently than fluoro, with kind of less prominent findings when comparing the opposite or looking at them being equivalent. In the middle column, we're looking at studies looking at penetration, and here we see a lot more studies. I'm kind of seeing that fees identifies penetration more frequently than fluoro, so about 82% of the studies had that finding. And here we're looking at aspiration, and here about 52% of the studies identified that fees saw aspiration more frequently than fluoro. But the opposite isn't necessarily true. It's not then that 48% of the other studies found fluoro to identify aspiration more frequently. It was really a mix of either that or that fees and fluoro were the same. And so across these studies, we're essentially seeing that FEES has the edge in terms of identifying functional swallowing outcomes. That was kind of my own kind of scoping review of the literature, but there was also actually a meta-analysis and systematic review that was done in 2017, and these authors came up with the same conclusion, that FEES appears to be more sensitive at identifying the frequency and severity of functional swallowing impairments when compared to video fluoroscopy, using that as the gold standard. So when I kind of take a step back and try to summarize the diagnostic advantages and limitations of FEES, I think that from a limitation standpoint, it's limited in terms of its assessment of swallowing physiology. And its advantage is assessment of functional swallowing outcomes. Using the term gold standard can be a little political, I feel like, nowadays, and I don't think it has to be. I think that when we think about gold standards, I think we just have to be more specific with our question. So it's a gold standard assessment tool for what? Neither FEES nor fluoro assess pressures. We can say someone has a weak swallow. We should not be saying something like that because we haven't measured pressures. The gold standard to look at swallowing pressures is pharyngeal manometry or esophageal manometry, right? So that's the gold standard for that. I would say that video fluoroscopy is probably the gold standard if we're trying to look at oral pharyngeal swallowing kinematics. It doesn't see everything, but it's the best tool that we've got, I think. And so I'd consider the gold standard for that. And I would consider FEES as the gold standard for looking at functional swallowing outcomes, especially when we're talking about pharyngeal outcomes. Certainly it could be missing something, but it appears when compared to the other instrumental assessments available to us, it's the most sensitive. So it's kind of the reference tool in my way of thinking. So now that you hopefully have an appreciation for diagnostic advantages and limitations of FEES, let's move on. I want to pose a clinical scenario, two clinical scenarios for you. Let's say you're a speech pathologist and you've worked in this field of dysphagia for 15 years. And let's say you've been working with your colleagues at your institution to develop standardized protocols for the performance of FEES, and you're using the following measures. All right, so let's say you're at an institution, you have friends and colleagues that you work with, and these are the measures that you all use for FEES interpretation. Let's say you use categorical ratings of none, mild, moderate, and severe to estimate the amount of residue that you're seeing on an exam. And let's say you use something like the 8-point penetration aspiration scale to describe the presence of penetration aspiration, maybe how deep it's going, and also the reaction to it. So is it ejected or not? And let's say you've got 2 patients on your caseload, okay? Patient 1. I'm going to ask you some questions in just a second, so I want you to pay careful attention. So let's say your first patient is a 70-year-old female with a history of basal tongue squamous cell carcinoma, and she's now 2 years out from chemoradiation therapy. Let's say you've engaged with them in a 3-month course of swallowing therapy, and she's been really she's done some jaw stretches, she's done lingual resistance training, she's done effortful swallowing, and all of these you're able to measure pre and post therapy. And pre-therapy, she was outside of normal limits when compared to norms, and post-therapy, she's essentially kind of in an atypical range, maybe within a normal limit range for these exercises. Okay, so her exercises appear to have gotten much better, and she's relatively within normal limits for these exercises now. Let's say before you started therapy, she came in with a FEES from an outside institution, and that FEES revealed that she had severe molecular residue with thin liquids and crackers and a mild amount of molecular residue with thin liquids. So that should say crackers up there. Then post-therapy, it should say pudding, there we go, sorry. Post-therapy, after the 3 months of therapy, she has severe molecular residue with pudding and cracker, and mild amount of molecular residue with thin liquids, right? So this is now the FEES that you've done after a course of therapy. So severe residue to severe residue, mild residue to mild residue. How would you then proceed in kind of clinical decision making with the patient? Would you kind of counsel the patient, chat with them, and talk about maybe continuing treatment using the same exercises? Because she improved with the exercises, despite the fact that we're still seeing kind of severe amounts of residue? Or would we consider changing to using different exercises, given that there are improvements in the exercises, but they didn't seem to generalize to improvements in swallow function? So I want you to think about that for like 10 seconds. If you're with colleagues right now, I want you to like share your answers verbally. So I'll give you 10 seconds to like chat with your colleagues, or if you're by yourself, just say the answer aloud. So which one would you do in this circumstance? Okay, I'm gonna go. So would your answer to what you just said, would it change if the following information was provided? I should say this will be my answer right now. I guess you guys can compare to my answer. I would probably do option 2. So the patient improved in her exercises considerably. She's actually now within normal limits with these specific exercises, and they didn't seem to generalize to improvements in swallow function. So in my head, I'm like, well, we tried, but apparently we didn't get the right exercises for you to kind of work on improvements in swallowing safety and efficiency. So let's maybe keep going with therapy, but let's try different exercises now. Let's go through another 3-month course of therapy and target something else. That would be the way I would probably talk through things, and that would be my rationale for potentially switching exercises. But would our recommendations change if the following information was provided? If pre-therapy, she had severe residue of the pudding and cracker, and it was characterized by 100% filling of the vallecula, and mild amount of vallecular residue, but it was characterized by about 25% filling of the vallecula. Then post-therapy, what if her fees continue to reveal severe residue, but now it's with only 50% filling of the vallecula, and she still had mild amount of vallecular residue, but now it's without 12% filling of the vallecula. In other words, there's a 50% decrease in our residue findings. Would that alter our recommendations? If you're with your colleagues, raise your hand if it would alter your recommendations. Be brave, be brave. If you're by yourself, be brave and raise your hand. Or don't raise your hand. And you can put your hand down and raise your hand if it would not alter your recommendations or how you're counseling the patient. So for me, I'm not sure. It might alter my recommendations. It would definitely alter how I'm counseling the patient. Because it provides a lot more kind of unknown. She still has dysfunction. Maybe they're not the right exercises, but here we are actually seeing a change in her swallow function that we weren't necessarily detecting or reporting beforehand. So we're seeing that her body is responding. There might be more robust exercises out there. We might want to add something or replace something, but we might want to stick with this for another couple of months because we are seeing steady improvements. And so I think we don't necessarily have the answer, but what I think this is demonstrating is that the types of measurements that we want to include in our clinical practice are assessment techniques that are responsive, meaning that they're sensitive to detecting changes and differences when changes and differences are actually present. So in this case, the patient was improving. She had a 50% reduction in her residue patterns. But the first metric of using these categories didn't capture that, despite the fact that changes were present. Whereas by using something like percentages, we're able to describe the changes in a little bit more detail. There might be some error in that, just like there can be errors in categorical ratings, but we are kind of making note that these changes are potentially present, and so it's a little bit more responsive. Let's say we have this similar case. We have a 62-year-old male with a 6-year history of Parkinson's disease. And this patient previously completed another 3-month course of cough and swallowing therapy. Post-therapy results are consistent with the last 2 phases that this patient had previously underwent, suggesting that the patient might have hit a plateau in swallow function and maybe rehabilitative gains. And so because of this, the patient's interested in transitioning away from kind of daily intense practice exercises and kind of weekly therapy sessions with the clinicians, and moving to more of a lighter maintenance load with routine follow-ups. So this is kind of the plan of care that the patient's interested in, and you think that it is a fine plan. And so they schedule a return follow-up fees in 6 months. So let's say this is their first fees right after the course of therapy where we're like, they've hit a plateau, you can move to maintenance after this. This is right before that maintenance period. And what we see is that this person has penetration that's entering the vestibule, remaining above the vocal folds, and is not ejected. So that's a PS of 3. And this occurred on 3 out of 6 thin liquid cup sips. And we also saw silent aspiration on 1 out of 6 liquid cup sips. So a PS of 8. Then they come back after their maintenance assessment, and so this is 6 months later, and we see that penetration occurred in 2 out of 6 liquid cup sips, and non-silent aspiration occurred in 1 out of 6 liquid cup sips. Right, so we have a PIS of 3 that occurred on 3 out of 6 trials, and then another PIS of 3 that occurred on 2 out of 6 trials 6 months later. And then pre-maintenance, we had silent aspiration ones, and post-maintenance, we had non-silent aspiration ones. So think about this. And I'm going to ask you how you think their swallow function is changing. Does it look like they are maybe relatively stable, but maybe a little bit improving? Do you think that they're definitely just stable, or do you think they're stable, maybe worsening? So raise your hand if you think they are definitely stable and unchanged. And I'm never definitive. I always hedge my bets. So if you didn't do that, that's great. Okay, do you think they're relatively stable, maybe a little bit improved? Raise your hand. Put your hand down. Raise your hand if you think they're relatively stable, but maybe a little bit worse. All right, and put your hand down. With that in mind, a similar question as before, would you continue with this maintenance program using the same practice load, or would you encourage the patient to undergo another course of intense therapy? So raise your hand if you would do the first option. Maybe the second option. Okay. So for me, I look at this, and if this is what I saw on a report, let's say I didn't actually see the fees, I would think that the patient's relatively stable. I don't know, maybe a little bit better. They had 1 less instance of penetration, and at least now they're coughing to aspiration, so that's good. And so I think because they're relatively stable and or maybe a little bit improved, my recommendation be if they're happy with it and if they're maintaining their health outcomes, let's stick with this. Let's continue with the maintenance route and see you again in another 6 months. And that would probably be the way I would counsel the patient. Unless they were interested in doing more therapy intensely, then great, and if we had the resources. Okay, but would our therapy recommendations change, and would our impressions change if the following information was provided? Pre-maintenance fees, they had penetration on 3 out of 6 liquid cup sips, but this was characterized by 2 to 8% of the laryngeal vestibule being covered in penetrant residue. And they had 1 instance of silent aspiration, just as we said before, and it's characterized by just about 2% of the subglottic shelf being covered. Then let's say after the maintenance, they had after their 6-month follow-up, we saw that there was 2 out of 6 liquid cup sips having penetration, so 1 event less of penetration, but these penetration events were characterized by 70 to 80% of the laryngeal vestibule being covered, as opposed to 2 to 8%. And let's say they still had that non-silent aspiration event, but here it's around 71% of the subglottic shelf being covered. So a much larger surface area, and likely the amount of aspiration, if we had to guess. So if this is what we actually saw, do our impressions change on if the person's stable, maybe improving, definitely stable, or stable, maybe worsening? For me, I look at this and I think that patient's maybe getting worse. So I think that the frequency is relatively the same. I mean, there's one less instance of penetration, but we only did 6 trials. So it's pretty frequent happening for this individual. And the amount of penetration and aspiration using these metrics, it's just an estimation, is substantially larger after the 6 months course of maintenance. So I'm inclined to think that the patient is actually worsening. I don't 100% know, but based off of these findings, it's about just as frequent, but much more is estimated to be occurring right now. And so I think because of this again alters my clinical recommendations, and this again alters how I'm going to be counseling the patient. So I'll be kind of talking to the patient like, we underwent this 6 months maintenance course of therapy. And it looks like while the frequency of airway invasions occurring the same, the amount seems to have become a lot more. And so maybe we need to be working, let's kind of go back to your swallowing exercises, let's do another kind of intense course of therapy, and then figure it out from there. So in this example, I think it does alter our clinical recommendations. And so what I'm trying to highlight here is that we want measures that are not just responsive or detecting changes when changes are present, but also valid. And so when I say valid, we're saying measuring what it's intending to measure. And what we were trying to look at here is the patient changing over time? And while we were able to talk about the frequency of penetration and aspiration, by not talking about the estimated amount of penetration and aspiration, we're missing out on a big clinical piece that's going to be altering our recommendations. And so we want measures that are both responsive and valid. And so I hope that when we finish this presentation and you go off into clinical practice, you're kind of reflecting on the various assessment measures that you're using, not just for fees, but for anything, including video fluoroscopy as well. But it's some of these gaps that led us to the development of VASES. So that gets us now to VASES. So VASES is the visual analysis of swallowing efficiency and safety. It's a standardized approach for kind of guiding how we're looking at and interpreting fees. I don't think of it as a rating scale per se. I guess you could use it as a scale, but really kind of a framework to guide all of our interpretation for functional swallowing outcomes. And it incorporates methods that have been previously researched for fees analysis and other assessment techniques that have been found to be both highly sensitive or responsive and also reliable and valid as well. So VASES focuses on functional swallowing outcomes. So when looking at kind of this framework again, it really focuses on functional swallowing outcomes, and that was deliberate. That's because that appears to be the diagnostic advantage of fees. We could have, included kind of measures of swallowing kinematics, but again, most of those would just be inferences. I think the vast majority of them would be inferences. And so really VASES is focusing on the diagnostic advantage of fees, which is functional swallowing outcomes. VASES was developed in large part to address a lot of the gaps that I was trying to highlight in some of those clinical cases, where it's developed to improve the standardization and transparency of fees analysis. It's also designed to increase the responsiveness and reliability of fees analysis, and I'll show some reasons why. Assessment of the amount of penetration and aspiration, not just the presence of it, and also because of the anatomic and temporal boundaries that are incorporated into VASES, it's intended to improve the generalizability between fees and fluoro by using very similar boundaries that are used for fluoro as well. So there have been lots of really wonderful rating scales that have been developed for fees, and everything has kind of its benefits and limitations. Some of the fees rating scales, though, from a limitation standpoint that have been developed is that are typically a little bit less sensitive and less reliable. So what we know within our field of swallowing, and it's not really just our field, but work has been done in the field of dysphagia, mainly by Dr. Jessica Paisenia, who's at Boston University Medical Center. And in other fields, it's been found that categorical ratings, methods of rating, are typically less reliable and less sensitive than using continuous-based rating methodologies. So when we're saying categorical ratings, we're saying things like mild, moderate, severe. Those are all, categories. They tend to be less sensitive and less reliable than continuous based methods. So things going from like 0 to 100, for example. So she has a series of work demonstrating that specifically for fees. We also know that categorical rating methods, which are used in a lot of the previously published rating scales, are, I would argue, probably a little less valid. There's not research to support this. This is just my thought. So take this with a grain of salt. But when I say less valid, what I'm saying here is that residue does not just jump from, let's say if we're comparing it to water in a cup, it doesn't just jump from nothing in the cup to the cup is now 25% filled to 50% filled to 75% filled. It doesn't do this. What it does, it can range any potential number. We could fill this cup up with water, we could stop at any point, and we could have a random number. Not random, but so if we are creating categories where categories aren't inherently there, then there's room to improve the validity of it. So residue has the capability of existing on a continuum. And so I think we should incorporate methods of measurement that reflect that kind of nature of that. I'd also say categorical ratings of residue specifically are less transparent. We might use the word mild amount of residue, and while we're using the same standardized term, I would put that in quotes, that might mean different things to different people, and we don't even know that it means different things to different people because we're not probably talking about it. So in dark gray, I have a variety of different fees rating scales that have been published. They're all really great tools. I've used them all. And all of them use the word mild in terms of their categorical ratings of residue. But you can see that in red, the definitions of mild changes for each rating scale. So if, let's say, you're a clinician and you use the Yale Residue Severity Rating Scale, and you're saying the term mild, but you're saying it to a colleague who uses the Boston Residue and Clearance Scale or BRACS, then you're using two different constructs, but you're saying the same word. And so you can imagine that that you might think that you're kind of connecting, but you might actually have very different impressions of how a patient is actually presenting. And so that's what I mean by less transparent. We don't really know that we're talking about different things because we're using the same words that have different definitions behind them. A lot of the fees rating scales, in addition to having categorical rating methods, a lot of them, while they used anatomic boundaries to talk about things like molecular residue and puriform residue, there were no scales that really clearly defined how do we define the molecula? How do we create boundaries for these different anatomic structures and temporal phases that we ultimately use to guide our ratings of our functional swelling outcome measures? So they would use terms without actually providing clinicians like step-by-steps on how to actually draw these boundaries. And without that, I would say we're again being a little less transparent. We're using the same words to describe anatomy, but we might draw lines very differently. So as an example, we can think about the anatomic boundary for just penetration, something we are saying all the time when talking about someone's fees or fluoro. And what I have highlighted here are various definitions for the term penetration across various researchers and clinicians. So in yellow is the difference in terms of the anatomic boundary associated with penetration. So in these top few, we say larynx or airway inlet. While this is somewhat specific, I think talking about these anatomic boundaries on fees is actually a little bit vague. Let me just make sure that's okay, great. These next kind of definitions, these are anatomic boundaries for penetration, including things like essentially the free end or the floppy part of the epiglottis. And in this lower group, penetration is defined as really not the floppy part of the epiglottis, but everything just within the laryngeal vestibule. assuming that the vestibule does not include the free end of the epiglottis. So across all of these researchers, we can see that we're using the same term for penetration, but different people are defining penetration differently, actually. So you can imagine if, let's say, here we are including anything on the floppy part of the epiglottis as penetration, these people are going to be reporting penetration likely more frequently than these people who aren't including that and only indicating it as things entering the kind of deeper vestibule. And so this really affects how we are interpreting research. It affects how research is generalizing to our patients. When we look at exams side by side, I think that historically, maybe this is shifting over the last couple of years, but historically we might look at these images very differently. So if we have, residue in these gray shaded areas where these red arrows are pointing to, if we look at the image on the left, if we saw a little bit of stuff on the tip of the epiglottis or the front of the epiglottis, most clinicians probably wouldn't say residue right there is penetration. I think historically, if we saw anything on the epiglottis up here, some clinicians very likely might have said that's penetration. But if we're looking at it side by side, the same part of the structure, just on different exams, it's the same structure. So ideally, we should be interpreting residue in one exam the same as the other exam. And that's what we're talking about when we say generalizability. We go a little bit lower down. Still, we're on the epiglottis here. And I think probably most clinicians still, if they saw residue right there, wouldn't say that's penetration. Again, many clinicians historically might have considered that penetration. We go further down. Let's say we go into the dark bands of the video fluoroscopy. This is what we think of typically as the vocal folds. Also, a really good study was just published that I posted on my Twitter feed recently that actually confirmed that. So that's good. That's what I've been using as a benchmark for the vocal folds for a long time. So this dark gray band would be the level of vocal folds on video fluoroscopy. And so I think most people, if we saw residue on or in this gray shaded area, that we would call that penetration to the vocal folds. And so this kind of gray area is demonstrating this kind of medial edge of the vocal folds right here. And I think historically, many clinicians might have considered this aspiration because it's below the top part of the vocal folds, even though it's still very much within the level of the glottis. And so I think comparing these two exams, one exam we might have said penetration, the other exam we might have said aspiration. And so not a great thing. And so I think what we understood was that there was for a long time a need to really standardize FEES interpretation, in large part by establishing clearly defined anatomic and temporal boundaries for rating things like residue, penetration, and aspiration. And so that's what we really intended to do with VASES. By creating kind of explicit anatomic and temporal boundaries and by incorporating percentage-based residue ratings using Dr. Jessica Pesina's work, and we really try to work on improving the standardization and also the transparency. And I think transparency is really key here. There's been a lot of other stuff that's standardized, but if it's not super explicit, then it's not necessarily transparent. Also improving the reliability and the responsiveness of FEES interpretation. And then by using similar anatomic boundaries and temporal phases as video fluoroscopy, we're also improving the generalizability between both exam types. So this helps us as clinical consumers to understand research, but then also as we are kind of getting into evidence-based practice and reading research, knowing how one study that might have used fluoro might relate to another study that used FEES. So VASES includes a variety of kind of rules associated with its framework. So what includes the actual outcome measures? You look at a swallow, what are the things you actually rate using VASES? We have the when, which would be our temporal boundary. So how do you define before the swallow, during the swallow, after the swallow? Where would be our actual anatomic boundaries? And how would be like the actual rating methodology, and then there's some various secondary rules. I should say too that I have a professional website, and on there's resources for VASES, like interpretation practice, and a kind of outline of some of these rules. So there's lots of resources, free resources on my website. And so what I'm going to do right now is really just kind of do a skimming of the rules and not so much interpretation practice, since there's other resources for that, and that would take a couple of hours in and of itself. So the what are our functional outcome measures. So what this is highlighting right here is that what one could do is they would watch a swallow. Someone drank, let's say, 20 mils of white water, and then they pause the video clip, and then they provide ratings for these 7 outcome measures. Rating these 7 outcome measures takes about a minute, probably less than a minute, to be honest. Viewing the swallow and then rating the outcome measures takes about a minute and a half. So the idea is that these first 3 bullet points, certainly oropharyngeal and hypopharyngeal residue would be measures of swallowing efficiency. Epiglottic residue, we're not quite sure where that fits in, to be honest, but probably more of a pharyngeal measure. And then we have our measures of swallowing safety, which include the amount of residue that we're seeing in the laryngeal vestibule, on the vocal folds, and in the subglottis, as well as using the penetration aspiration scale. So that's also included in the VASES. So in terms of when, so this is kind of the what, our outcome measures. In terms of the when to rate, we have our temporal boundaries. And so with VASES, we define 4 temporal boundaries. We define before the swallow, during the swallow, after the swallow, and then what's unique for FEAS is the between bolus trials. Because we have this continuous viewing, we needed to kind of capture something that's happening between our various trials. We have in the original article definitions to characterize how do you define the before the swallow, the during the swallow, and after the swallow. And for each of these 4 boundaries, there's an onset and an offset. So we define what is the onset of the before the swallow phase, and then when is the very end of the before the swallow phase, or the offset. When is the very beginning of the during the swallow phase, when is the very end of the during the swallow phase. And then same thing with after and between bolus trials. And this is important because this guides when we provide ratings for our 7 outcome measures. The 6 residue ratings that we make, so the residue for the oropharynx, hypopharynx, epiglottis, vestibulovocal fold, subglottis, those 6 different residue ratings are intended to capture what we see at the offset of the after the swallow phase. So it's at a very specific point in time, because bolus can flow constantly from one region to the next. So it's important that we try to standardize when we are providing our residue ratings. And so the way VASES is currently published and constructed is to provide those ratings of what we see at the offset of the after the swallow phase. We can also provide ratings of penetration aspiration for each swallowing trial, and not really a primary outcome measure, but something that you can add, I guess, if you're interested, is looking at bolus location at swallow onset. So when we are looking at the during the swallow phase and we have identified the onset of the during the swallow phase, pause the video and then see where do you see residue. And then you can use our anatomic boundaries to say we see residue in the oropharynx and in the hypopharynx. So you would just mark every location that you're seeing a bolus at the onset of the during the swallow phase. So we've talked about the what of VASES, we've talked about the when of VASES, and now we are going to talk about the where of VASES, which are our anatomic boundaries. And essentially what we do by creating these anatomic boundaries is we go from looking and seeing an image like this to kind of doing this in our head. So our brain should slowly separate, okay, this is how we're defining the oropharynx, hypopharynx, epiglottis, vestibule, vocal fold, subglottis. So these are just imaginary lines in our head. They're not something that you're doing with the computer. But the idea is that we're standardizing our interpretation from this to being much more specific. So you and I can all know that we're talking about the same structures. So let's talk about how to create some of these different boundaries. Let's talk about the boundary that separates the oral pharynx from the hypopharynx first. So to create the boundary separating the oral pharynx and the hypopharynx, the very first thing that we do is with our eyes, we try to identify the points where the right and left epiglottic folds merge into the epiglottis. So if I was to put a couple of white X's on here, I'd put them about right there. So if I go back, we can kind of see this gray line that then of the epiglottic fold that then kind of morphs into the epiglottis. You can kind of see how it trifurcates. What you're thinking about is where does this medial edge become indistinguishable from the free end of the epiglottis. So doing that on both sides, we have approximately the 2 points right there where the epiglottic folds merge in the epiglottis. We then draw an imaginary line across the screen with our brains. And then what we say is that everything above that line and or in front of it is the oral pharynx. I need to change this image because I think this plane should actually kind of extend around, and so some of this should actually be yellow up here. So you're really thinking kind of superficially, right? Because this is a tube, so you want to get everything above the tube and also in front of it. So all of this yellow would be the oral pharynx. Within the oral pharynx, we have the vallecula. And so the vallecula is defined as going from the rim of the epiglottis straight across the base of tongue. So in VASES, we also define the rim of the epiglottis as the point where the lingual surface of the epiglottis and the laryngeal surface meet. I know that other clinicians and researchers will say that the rim of the epiglottis is maybe like the highest part of the epiglottis. We didn't feel like that was maybe the most reliable because we think that kind of maybe changes based off of where the camera is. So really we're trying to conceptualize where does the laryngeal and the lingual surface of the epiglottis meet. That would be the rim. And then from there, we go straight across at a perpendicular degree angle to the base of tongue. So oral pharynx, and within the oral pharynx is the vallecula. On the other side of that line, we have the hypopharynx. And so within the hypopharynx, we also have the piriforms. And we've defined the piriforms in VASES as going from the epiglottic folds straight across to the posterior pharyngeal wall. Epiglottic folds as well as the arytenoids. We did this for a couple of reasons. In FEES, you might be used to hearing things about like lateral channels, so kind of like over here, but not everybody has these very clear lateral channels. We also couldn't identify ways to reliably define exactly where the lateral channel stops and starts and where the piriforms like definitively stop and start. Like, how do you distinguish the lateral channels from the piriforms? And we also abandoned lateral channels, not just because of that challenge, but also to improve generalizability with fluoro. And so in fluoro, we're not necessarily talking about lateral channels typically. And so it's the piriforms. So we're thinking about this three-dimensional space between the epiglottic folds and arytenoids to the posterior pharyngeal wall. Things that we're also thinking about here is that when we're talking about the epiglottic folds, we're really talking about the medial superior edge, not the middle and not the lateral. So as much inward as we can go on the superior surface before we kind of drop off. So things are much more medial rather than on top. So this would be the boundary then for the piriforms going straight across at a perpendicular degree angle. And so that three-dimensional space is the piriforms contained within the hypopharynx. Our next anatomic structure is the epiglottis. And so to outline the epiglottis, which is really the laryngeal surface of the free end of the epiglottis, it's the flappy part of the epiglottis is what we're talking about. So there's really kind of two different levels. To identify this, what we are just kind of casually calling the epiglottis, is identifying those same 2 points. We try to keep life easy. Then what we're doing is we want to try to find the trough, kind of the deepest point between the epiglottic petiole, which is this bump right here, with the floppy part of the epiglottis, or the free end of the epiglottis. So identifying that trough, kind of the deepest part, not necessarily the middle, but like the deepest, between the petiole and the free end. And then we connect those 2 points with that curve. This area can be a little challenging, and so you just kind of hope for the best as you connect the line. And the idea is that while we still might not be 100% like in line with each other, like you might think the trough is a little bit different than where someone else might. The point is that we're going from not talking about this at all and not being at all specific to being much more specific, even if how I'm interpreting something is a few pixels off than how you're interpreting something. We're talking by a few pixels now. We're not talking like off by like hundreds. So I don't, it's all still visual, it's just perceptual, so we're never going to be 100% perfect. And I think that's really important to keep in mind as you start to integrate this into practice and into your own experience. Don't get frustrated if you're not like completely on board with your colleagues, or if you're looking at some of my videos. The idea is that we are trying to be much more specific, but we're never going to be 100% perfect. Okay, so we have these 2 points, we find the trough, we connect the two, and then everything above that along the rim, within that, that's what we call the epiglottis, or the laryngeal surface of the epiglottis. The full term would be the laryngeal surface of the free end of the epiglottis, but that's a mouthful, so we just say epiglottis. And so notably, anything within this yellow shaded region, what we're calling the epiglottis, by VASES standards, we don't consider that penetration. So this would be a PS of 1. So may be included in some sort of measure of pharyngeal residue, but we're not including that in our measure of airway invasion and swallowing safety. So it's not penetration according to VASES. And that was in part to kind of be in line more with the video fluoroscopy literature as well, which from the researchers who have kind of described these anatomic boundaries are not including that. Our next anatomic boundary is the laryngeal vestibule. So this is using that same boundary that we just created. And then the boundary of the hypopharynx. So kind of that medial superiormost edge. And then circling that around. And so that would be our boundary for the laryngeal vestibule. Notably, the vestibule does not include this postcricoid tissue, but it does include kind of this interrythmoid tissue, kind of where you see the color and texture change a little bit. And really, you should be thinking as most medial as you can get. And so if the vocal folds are AB versus adducted, your interpretation might change a little bit because the arytenoids rotate as they go in and out, right? It's not just a V, there's actually 3-dimensional rotation with the vocal folds. And so you're really thinking about the most medial. And so what we're trying not to do is just say everyone has penetration because they had something like on one part of their arytenoids. So we really want to be on that medial plane to be entering into the vestibule. Notably, this is what we consider the first point of penetration. So penetration is not here, it would be in here. And so this would be what would be our PASs of 2 or 3. Our next anatomic boundary would be the vocal folds. And so I have a image drawing of the vocal folds here in this coronal plane. I think that sometimes we lose perspective of kind of the depth of the vocal folds and the glottis. So you'll see if we're looking here, we have our base of tongue up here, our epiglottis. We go down, we have our ventricular folds right here. We have this little space, that's our ventricles. When we're using FEES and we have our camera is looking down, and this is kind of our axial viewing plane looking down. And so oftentimes on FEES, we don't see the space because it's hidden, essentially. But there is a space there, it's called the laryngeal ventricles. We then have the superior part of our vocal folds right here. We then have this medial edge and it extends all the way down here. Like these are all the vocal folds. And I think with our endoscopic viewing plane that we see here, we oftentimes don't see that medial edge. And so we just start to think of these as like 2-dimensional sheets. But they are probably longer down than they are wide. And so their superior surface is actually a little bit smaller than the medial edge of the vocal folds. And so I'm bringing this up for a couple of reasons, because when we think about the anatomic boundary for the vocal folds, we're including a couple of different things. In vases, if there's something in this space in the ventricles that sometimes we see as like a little shadow, we consider that as on the level of the vocal folds. We also have the superior surface of the vocal folds, highlighted here in blue and highlighted here in blue. So that would be the vocal folds as well. And then we also have the medial edge of the vocal folds, highlighted here in blue and here in blue as well. And so for vases, all of this is considered the vocal folds, and even stuff that's between the level of the vocal folds, even if it doesn't look like it's contacting the tissue, if it's still contained within the level of the vocal folds, we're calling that the vocal folds. We're calling that the level of the vocal folds because that's the level of the glottis. So anything in this blue or yellow would be considered, so this is all of the vocal folds, right? Including the yellow space. So anything in this region would still be considered penetration to the level of the vocal folds. So even if we had like residue being this yellow circle oval thing right there, that would still be considered penetration. That's not aspiration, according to VASES. If you disagree with that, that's totally fine. And so, I mean, I don't think it's totally fine, but if you did do that, I think the important thing about VASES is the transparency behind it. So you might say something like, we're using VASES, but anything between the vocal folds, we consider it aspiration. And then at least everyone knows, like, okay, I know like the exact framework that you're using and you've made this adjustment for whatever reason, but at least we could replicate like how you interpreted these results. I don't encourage doing that, but I think by having this level of transparency, it allows a little bit more freedom on the clinician as well. Our last anatomic boundary is the subglottis. And so this is everything below the lowest level of the vocal folds, or the lowest level of the glottis. And so we have the subglottis down here, and we can kind of separate the subglottis into a couple of different structures. We have the subglottic shelf, which I've outlined in this kind of dashed triangle. And so that goes from the lowest level of the vocal folds up to the ridge. Once we get to the ridge, then that's the cricoid cartilage, and most of the time. And then below that is the trachea. That might be the trachea, but it's typically the cricoid cartilage. And so it's important that we're separating the subglottic shelf from the rest of this because it influences how we're going to do our ratings, which I'll go over in just a minute. So this is essentially a summary of our anatomic boundaries and actually how it might line up theoretically with video fluoroscopy. So if we're looking at the left image, in one we have our oral pharynx, and if we look at the image on the right, everything in yellow would be the oral pharynx. We go a little bit further down on video fluoroscopy, we have the hypopharynx, and that's what's supposed to be lining up with the hypopharynx on our endoscopic image. We have the epiglottis here, which I've just highlighted here in darker red. We have our laryngeal vestibule, our vocal folds, and our subglottis. And so this is essentially how it's trying to map onto video fluoroscopy. So we've talked about the what, which are outcome measures, our 6 residue ratings, and our PAS. We've talked about our temporal boundaries, the when. We've talked about anatomic boundaries, the what, or the where. And now we have how to actually do the ratings. So how do we rate pharyngeal residue? When you are rating pharyngeal residue, we have our various measures. Let's talk about oropharyngeal first. You ask yourself the question, how full is the vallecula with oropharyngeal residue? That's your question. How full is the vallecula with oropharyngeal residue? So if you go back to this image, what we're really asking ourselves is look at anything that's in the yellow region, anything that's in the yellow, and then using a little bit of imagination, it is imagination, you're going to put it into the vallecula, like scoop it all and push it into the vallecula. And then you ask yourself, if all the residue that you saw in the oropharynx was pushed into the vallecula, how full would the vallecula be? So we're kind of normalizing our rating to the size of the vallecula. If we did the hypopharynx, then the question is, how full are the piriforms with hypopharyngeal residue? We do the same thing. Look at anything in the yellow shaded region, understanding that some of that's probably oropharynx. Put it all into that 3-dimensional piriform space and ask
your question, how full are the piriforms with any residue that was in the hypopharynx? So if we saw like pudding or cracker like on the pharyngeal wall, we'd push it down using our brains into the piriforms, something like. Normally, if it's liquid, it's going to already be in the vallecula and it's going to already be in the piriforms. But if it is food textures like pudding or cracker, it might be stuck on the base of tongue or on the pharyngeal wall. And in that case, you might kind of push it down into those little pockets. Once you ask yourself these questions, you're going to provide a number that goes from 0 to 100. So when VASES was originally developed, we used a visual analog scale. And so the idea with a visual analog scale, if you haven't used one before, is that it's a line and it goes from 0 to 100. Classically, it was pen and paper tests, and the line was 100 millimeters. And so the leftmost part of the line was 0, the rightmost part of the line was 100, and you'd place a tick on it. And then you take a ruler out and you measure where the tick was relative to 0 in millimeters. And so let's say you placed a tick or a circle right here, then the rating might be something like 65 or 70. So that would be one way to rate it. In our follow-up validity study, we looked at the ability for clinicians to just use verbal numerical ratings. Like, could they just say a number rather than having to do a visual analog scale, which is good for research, but not great for clinical practice? And we found that, yes, clinicians are very accurate at actually just saying a number. Likely in large part because in order to do the visual analog scale, people were thinking of a number and they were trying to match it to the scale. So we actually are kind of cutting out a step, I think. So if you ask yourself the question, how full is the vallecula with oropharyngeal residue, you would say 30% or 35% or 33% or like whatever percentage you think it's full. So if we looked at this image here and we're judging the white, we are thinking about three-dimensional filling of the vallecular space. And so notably, with both the vallecula and the piriforms, you need to be standardizing essentially the size of the space. So you want to think about when the vallecula would be its essentially largest. Even if you don't get an image of that, you want to think about if the tongue was separated a little bit more from the epiglottis, and that's something that the patient could reasonably do, how full would that vallecular space be, right? Because if we're judging the base of tongue as it's essentially hitting the epiglottis, the vallecular space is really small and a little bit of stuff might be filling it up 100%. So we need to standardize the housing space of the vallecula and the piriforms. So it should be when the vallecula appears its largest or when the piriforms appear their largest as well. So if I was just to judge this image, I would say 1%. Like they're probably less than 1%. We see something there, but it is not filling up that three-dimensional space. So 1. Here, if I was to look at this image, we can see that we could probably create a little bit more of a vallecular space. And we ask ourselves the question, how full is the vallecula with oropharyngeal residue? And I'm mainly just judging these little pools right here, since the rest of this is just like trace coding. So I might say, oh, I think that the vallecula is 30% filled. If you thought that, then you would say, I think I could get 3 of these in here before it's to the rim and on the verge of overflowing. And then I would say 30% is way too much. I think I could get a lot more than 3 of these before it starts to overflow. So then I might say, I don't know, I think maybe about 10% filling. So if I said 10%, then I would say, essentially, I could get 10 of these in here before it fills all the way up to the rim of the epiglottis, assuming the vallecula is a little bit bigger, and then we start to get overflow. And I think even that's an overestimate. So it might be something like 5%. Okay, we could get 20 of these in here before it starts to overflow, and that I actually feel pretty good about. So I might give this a rating of about 5%, 5% filling. So I think about 5% of the vallecula is filled with oropharyngeal residue, right? And so we're using these arrows as kind of like the top boundary of what the vallecula would be, noticing that the tongue is a little bit retracted here, and we could probably open that space up just a hair. If we look at this image, however, I might give this a rating of around 90%. It looks like around 90% of the vallecula is filled with oropharyngeal residue. It looks like at kind of this kind of superficial-most level, superior-most level, that there's maybe a little bit of airspace right here. So if I was like a little person swimming in this pool, I could probably stick my head above air right here. That's a weird analogy. Sorry about that. Yeah, I think maybe around 95% filling before it's overflowing. So if I'm stuck between two ratings, 95, I just kind of cut my averages. So I might say 92% or 93%, something like that. So then we can get to our airway structures as well. But because these don't have pockets, our question changes a little bit, and it's about how much of the surface area is covered with residue. So there's a little bit of a double standard here. If we talked about the vallecula or the piriforms, we're saying how filled is that space? So the mucosa could be 100% coated with residue. But if it's just coating and it's not, for example, if all of this was coated, but it wasn't actually filling up, it's a low number. It's still, let's do this one. If this entire thing is coated, I would still give that rating around 2% because it's not filling up the vallecular space. It's not filling that three-dimensional space. So for vallecula and for piriforms, we're really talking about how filled is that space, not how covered is it. But that is different when we compare it to the airway structures. So airway structures, we are talking about how covered it is because there isn't a pocket for it to fill up. So we ask ourselves how much of the surface area is covered with residue, and we use a number that typically goes from 0 to 100%. So we want to think about, when we're doing these ratings, the entire anatomic space or surface area, even if you don't visualize it. But we never make judgments that residue somewhere if we don't actually see it. So there's, again, another double standard here. We think about visualized and non-visualized anatomic space in terms of the total surface area or anatomic boundary, but we only judge the residue that we see. So we never guess or infer. So if we look at the epiglottis here we're looking at, I would say, maybe around 3/4 of the epiglottis. So you can see that some of the epiglottis is cut off. So we're seeing around 75% of the epiglottis. And we don't see any residue here. Here I put some, using some image software, I put some of these blue dots on here, right? So keeping in mind that we are only seeing around 3/4 of the epiglottis, here we're only, these blue dots are covering only about 2.1% of the epiglottic surface area. I know this because I analyze these on using ImageJ, so which is an analysis software. So I think in terms of calibration, this is kind of shocking. The first time I looked at this, I was very shocked that this is only representing about 2% of the epiglottic surface area, assuming we're only looking at 3/4 of the epiglottis. If we only took into account what we are seeing for anatomic space, just for the purposes of your calibration, this is representing 3% of the surface area. So these 4 dots are representing 3% of the surface area, meaning we could get around like 35 of these on here before this is completely covered. If we go to this image, there's about 35% covering of the epiglottis, thinking about the visualized and non-visualized surface area. So here around 35% of the epiglottis is covered. And if we are only thinking about the visualized surface area, it's around 47%. And I think some people might be shocked by this. They might have given this a much higher number. And I think the reason why some people might give this a larger number on the front end of things is because what people are doing is, I'm suspecting, is looking at kind of the spread of the residue. We kind of see how it's covering a lot of the epiglottis in terms of parameter, but you can see that there's lots of space in between these blue dots that isn't in contact with the residue. So if you compare that image with this parameter to this one, we can see it's the same parameter, but now we have like a blanket effect, like everything is actually covered here. And so here around 60% of the epiglottis is covered with residue, taking into account the non-visualized surface area. For your calibration, for your own eyes, if you're only looking at this picture here, this is around 80% covering. So what I oftentimes do when I'm looking at these airway structures and I'm thinking about covering or contact, what I typically do is I think about the spread or the parameter. And if we do not have this blanket effect, I typically cut my rating in half and then I give or take depending on how much of a blanket we have. So here I would have looked at this, and if I'm just thinking about the visualized surface area, I would think around 80% of this surface area there's like spread there. But it's not a blanket, so I'd cut it in half. That brings it down to 40. And I don't know, I'm happy with actually around 40. I don't think it's too much of a blanket or too sparse. And that actually lined up really well with what we got when we looked at it with ImageJ, right? So here, this looked like this was around 80% filling. If we're only looking at the visualized surface area, we cut that in half. That would bring us to around 40%, and this was actually measuring at around 47%. I probably would have gone up a little bit. So that's just to kind of give some perspective in terms of percentages. So how we rate residue, it's going to be the same for the epiglottis, the vestibule, the vocal folds. So that the same thing that we do for the epiglottis is the same thing that we would do for the vestibule and for the vocal folds. So we are looking at the entire surface area and we're asking ourselves how covered is the structure with residue. The same thing holds true for the vocal folds and also for the subglottis, but there's a little bit of difference when we're talking about aspiration. So because the trachea goes on forever seemingly, what we did with VASES is we said, okay, of everything that you see in the subglottis, including the shelf, the cricoid cartilage, and the trachea, pretend to put it all into the subglottic shelf and ask yourself how covered would the subglottic shelf be with all subglottic residue. So for example, if we saw residue in the subglottic shelf and we saw some in the trachea, then what we would do is with our brains, we would move all of this into the subglottic shelf. And then we ask ourselves how covered is the subglottic shelf, including both the visualized and the non-visualized surface area. How covered is that with any sort of subglottic residue? So kind of like what we did with the oropharynx and the hypopharynx. And in this example, this is around 24-25%. It's actually 23.7% when looking at the visualized and the non-visualized surface area. And so this rating, this could go above 100%, right? We could theoretically, if we had like the entire trachea covered, it could be looking like it's more than 2 subglottic shells. So we might have a rating of like 150% or 170% or 200%. It's possible if they aspirated the Dickens. So that's kind of quickly covering the rules and how you would go about kind of doing these ratings, how you can kind of think about the anatomic boundaries, the temporal phases. So I want to quickly end with how you might integrate this into clinical practice to show you kind of how feasible I think it is. And the very first thing to keep in mind is that it's a framework. It's mainly how you are thinking about phases and how you are looking at structures and talking about timing and talking about ratings. So you could, even if you are going to use other categorical scales, it still helps to, I think, increase the transparency of how you're rating. So if you're using a scale, but you're kind of using it with the VASES framework, then everyone knows exactly what you mean when you say molecular. Everyone knows exactly what you mean when you say piriforms or hypopharynx or during the swallow or after the swallow. So I think that is a important takeaway when you think about how you're using this in clinical practice. It's just knowing kind of the framework or the lens that you're looking at phases with. But a little bit more concretely, if you were to kind of provide VASES ratings, what you would do is the very first thing you would do is determine which swallows you're going to start rating using VASES. What I do is we at our center, we have a standardized protocol that we use. And so for the swallow trials in that standardized protocol, all of those swallow trials are getting rated by VASES. We're pretty quick at rating it. It's like I said, it's about a minute per swallow, and we have 9 or 11 swallows in our standardized protocol. And so we're reviewing the phases anyway, and then adding the measures doesn't take too long. But it might feel like a lot. So you might start off with saying, we're just going to rate one specific swallow, or we're going to rate all of the thin liquids or all of the puddings, or like, one type of swallow condition, or you might do one swallow across a couple different consistencies. So the first thing that you're going to want to do is you and your colleagues are going to figure out which specific swallows you're going to rate using VASES. Ideally, it's all of them within a standardized protocol. Then view that swallow trial of interest and rate each outcome measure. So you're going to rate a swallow, you're going to view a swallow and then rate the 7 different outcome measures. And as I mentioned, this takes about 1 minute. So here would be an example. We just watched a little swallow. We're waiting until the end. We're waiting until we start to advance the scope. We get a nice view of everything. Here we see the piriforms at their largest. We saw that the base of tongue was kind of further away from the epiglottis and what that housing space might look like. I have an Excel spreadsheet that I use that I have available for all of you as well. You certainly don't have to use an Excel spreadsheet. Just wanted you to conceptualize how you might do this. So I'm looking at these various measures and I am synthesizing my ratings, and I have a pretty good sense of everything now. So they did one swallow and a lot of these measures were really low. Epiglottis was the one that was maybe the hardest to rate. There's all of our residue ratings. I provide a couple of PIS ratings, what happened before, during, and after the swallow, what happened between bolus trials. It calculates the max. And then if I wanted to, I could add bolus location at swallow onset. I think if you include bolus location on swallow onset, that measure takes a little bit longer. If you don't use it, you're probably looking at like 30 seconds per swallow. So here we're looking at the onset during the swallow phase, identified where bolus was and where it wasn't. And there we go. That's how you provide ratings for VASES. So that's how you like integrate and do the actual ratings, is determine what you're going to rate, view the swallow, and then get the ratings. You might then want to compare that to norms. So we recently published preliminary norms. It's just from 39 healthy adults, so it's certainly not a large sample size. But we did this because it actually lines up with Dr. Katrina Steele's recent work, where she provided preliminary reference values for video fluoroscopy. So we thought it was a good, like, kind of convenient sample starting point. But the idea is that we will be building on this much more. But this article has a normative reference values, and there's it kind of just outlines in our protocol what we saw. The idea with this study is that you would actually just go to the supplemental document associated with the study, and in the supplemental document, it has norms for each specific swallow trial that we did. So if you're using a different protocol, you can say, all right, well, we're not using the same full protocol that James used in this study, but we are using a 20 ml white swallow, so let's look at norms for the 20 ml white swallow. Or we are using patient river volumes of green opaque water, so let's look at the norms for that. So you can kind of pick and choose what swallow condition you're currently using in your protocol, and then look at norms for that swallow. So that can help you make more of an educated guess on, is the patient presenting very typically, maybe a little atypically, maybe very atypically. And so this is what we do as well. There's a really great rating scale that was published a couple years ago by soon-to-be Dr. Heather Starmer and colleagues, Dr. Kate Hutchison. For those of you less familiar with this, the scale is called the Dynamic Imaging Grade of Swallowing Toxicity, or DIGEST. That was the original scale. It was developed for video fluoroscopy by Dr. Kate Hutchison at MD Anderson. They revised it slightly, so there's a version 2 that you should be aware of, and that I think was published in 2022. Heather Starmer also does lots of work in people with head and neck cancer. She's at Stanford, and so she worked with Dr. Kate Hutchison and all the other co-authors on here to create like a FEES version of DIGEST. And so they came out with that a couple of years ago. And so something that we're looking at, something that we presented on at the Dysphagia Research Society in spring is, can we kind of combine VASES and DIGEST? So with DIGEST, you get an overall grade on someone's swallow function. So you could walk away from the exam saying someone has mild safety impairment, mild deficiency impairment, and mild overall impairment. Like you can kind of talk about someone's severity in terms of these these severity ratings, these impairment grades. So it's meant to kind of provide an overview at the protocol level of how a person is functioning, but VASES does not. VASES just looks at the individual swallow trial level. So in some research that we did that we are submitting for publication, is can we use our VASES ratings from a standardized protocol to automatically derive digest fees grades? And it appears as though we can. We need to do some additional research and investigation, but it appears as though our VASES ratings can be used to derive a digest grade. This is a breakdown of how you might use digest. Essentially, that you get 3 grades from it. You have a safety grade, so these terms should be familiar from the beginning of this lecture. So using what you would do is across a standardized protocols, you identify the maximum PIS score, and then from there look at the frequency and or amount of that to get a safety grade. And so these grades range from 0 to no impairment, or 4, which would be a profound impairment. We can also have an efficiency grade. So for across entire protocol, you identify what's the maximum residue rating, and we have our percentages. So we can stick our percentages in here. And we talk about what consistency it occurred on, and then we look at which grade it is. So we could say someone has maybe moderate safety, maybe mild efficiency, and then what we do here is we look at the interaction between the two to get an overall impairment grade. So I think a moderate safety and a mild efficiency would be a moderate overall impairment grade. And so the reason why I'm bringing this up is this is actually what we are currently using in our clinical practice, given some of this preliminary data. We need the research on it, but that should be coming soon. But this is how I essentially lead the impression section of our report, is that this patient presents with, a moderate overall impairment in oropharyngeal swallow function with moderate impairment in swallowing safety and mild impairment in swallowing efficiency, and that these were derived from VASES grades. So it's very transparent in terms of how we got to these grades. So this leads us to how we might further talk about VASES with our colleagues. I think VASES is pretty intuitive to use in terms of report writing and speaking. I think when you first think about VASES, it's like, oh, there's like these percentages and it sounds kind of, I don't know, abstract or something, because I feel like we're so used to saying things like mild, moderate, and severe. But to be honest, I think this is much more transparent and actually a lot easier than we might initially think. So instead of saying something like patient presents with moderate amount of molecular residue, which cleared to trace amounts after a couple of swallows, we might say something like patient presents with about 40 to 50% filling of the vallecula with oropharyngeal residue, and that cleared around 5 to 10% filling with a couple of extra swallows. And so, I mean, I think this sounds a lot more transparent. Again, they're just estimations. Our percentages are not spot on, so I'm happy to give ranges. But yeah, I think this is pretty transparent and pretty easy to say. If we thought about it from a penetration standpoint, we might say that instead of saying patient presented with intermittent penetration into the vestibule, we might say that they presented with intermittent penetration into the vestibule, and when penetration was present, it covered around 30 to 40% of the vestibule. So rather than just not talking about the amount at all, we can give an estimated range of how much tissue was covered. This, I think, is especially important when talking about aspiration. So instead of saying that patient presented with intermittent aspiration with 2 events of silent micro amounts of aspiration and 1 event of non-silent gross amount of aspiration, because we used to, I mean, I don't really ever say these terms, but certainly I think a lot of people used to or currently say things like micro aspiration or gross aspiration, but we could just as easily say percentages. So we could say that they presented with intermittent aspiration. 2 events were silent with residue covering around 2 to 10% of the subglottic shelf, and 1 event was non-silent covering around 40% of the subglottic shelf. And so we could easily kind of give estimated percentages to describe the amount of aspiration that we're seeing as well. In terms of actual report writing, I have a table in my report that you could fill out. So this is actually the standardized protocol that I use at our clinic. And so what I do in my report is I'll have an outcome measure of interest, and I provide a 1 to 2 sentence blurb about it. So I provide the reference and why it's being used. And so this is essentially the blurb that I would have for VASES. And then you could provide ratings. So just like you might do something like this for MBS-IMP, you could do the exact same thing for VASES, and then just kind of type in numbers. Again, if you're just doing a couple of swallows, this would just be a couple of rows, and then you have your PAS at the end. And then this might be what the impression section of a report might look like. So for me, as I mentioned, I typically lead with digest. Again, we still need the research to confirm that this is valid, but it appears as though it probably is. So I'd lead with kind of my overall statements of their function plus additional sentences. And then very easy to kind of talk about in kind of prose writing. So we could say penetration of the vestibule was observed for, 20% of trials, covering 5 to 20% of the vestibule when present. Penetration of vocal folds occurred for 5% of trials, covering 5 to 10% of the vocal folds, and aspiration occurred on 20% of trials, covering 10 to 20% of the subglottic shelf. Pretty easy, I think. So if you're not aware, this is the website that I have. It's here for free resources for you all. jamescurtisphd.me. That's like the Apple website. That's not me talking about me. So you can see on the top we have a tutorial section, and in there you can see tutorials on VASES, which there's opportunity for more interpretation practice. The example Excel spreadsheet that you can use, you can download it and use it as you like and adjust it as much as you need. I have a written report template just of like a VASES, like VISA section. It's very bare bones, but you can use something like that as well for your own clinical documentation. I update my templates like every week, so that template will probably be different in a couple months. And just a lot more references and other details about VASES for your kind of continued learning, but that's certainly there. If you don't have access to the original publications for VASES, because one was through dysphagia, so if you're a DRS member, you should have access to VASES, and if you're ASH member, you should have access to one of the other articles. But if not, you can go to the free publication section of my website, and those are all self-archived versions, so they're less pretty, but they're free for you to download there as well. So that's everything. I'm happy to take questions at this point. And there was my hour and a half. Perfect. Happy to take any questions.
Brilliant. Thank you, James. That was fab.
Okay.
We've got a couple of questions here that have come in the chat for you. If you're happy to take them. Oh, you're muted.
Yeah, is that better now?
That's better. That's much better.
Okay. My camera's very weird. Is my camera weird? Have I been like this the entire time?
You were like that the entire time. I don't know whether it was intentional,
okay.
but it was.
No, I did not do this intentionally. Okay. Anyway.
Cool. So we've got a couple of questions here. So somebody's asked, given that we can't see the whole surface area of the subglottic shelf, but we are considering it when devising the proportion of coverage, how do we account for the unknown coverage of the unvisualized area?
Yeah, I think there's a couple of responses. So I think the very first thing that is important to do is when you start a FEES, I think this is why it's critical to do a little bit of a like anatomic assessment of them. So kind of doing a pre-swallow kind of visualization. And so this is actually where I get not just for the subglottic shelf, but I get an understanding of their true kind of molecular space and piriform space. So for thinking, I'll kind of start from top to bottom. So I'm thinking about molecular space. When their tongue is maybe a little bit more forward, or their chin is like in a, not necessarily tongue up, but like if their chin is in like a more of a neutral position, we have more separation from the base of tongue and epiglottis. That to me is a representation of their true molecular space. In terms of their true piriform space, if they can say E and they can adduct their vocal folds, then that is their piriform space at its largest. If they've got an immobility and they can't, then that's their true space, right? So it's whatever their potential essentially largest is for that as well. And I think for the subglottic shelf, it's the same thing. So we should be able to see the entire subglottic shelf, assuming their anatomy is like not terrible. In that digest research study that we're doing, it was done in people with head and neck cancer, and some of them had pretty edematous vocal folds and subglottic space where you don't necessarily see the entire subglottic shelf. But still there, then what you're doing is you are kind of conceptualizing, okay, well, the vocal folds probably end there. And so you have, hopefully you can see like the cricoid cartilage, right? Otherwise, they've got like some severe stenosis. And so we are, ideally, you're spending the time to like maybe have them a head turn. You should be able to get a view of the entire subglottic shelf, but if not, then you might have to do a little bit of inferencing and imagination of like where that actual space is, assuming it's actually there and they don't have some sort of surgical excision or something.
Great, thank you. And the next question, I suppose, is kind of slightly similar in terms of commenting on kind of what do you do about if someone's got altered anatomy. So if space is limited, but I suppose as you're saying, you have a really good look and see what you can see to kind of get your totals first.
Yeah, and I think that I get that question a lot, and I think that's a really important question. So I think like if someone's anatomy is altered, we still want to be judging them for their anatomy at that given point in time, understanding that it might change. So if someone is really edematous, we're still judging it for that specific FEES exam. And if they become less edematous over time, then we're judging it for that specific exam. And the reason for that is anatomy plays a huge role in our functional swallowing outcomes. And so if I heard that someone had a hypopharyngeal res reading of 100%, regardless of if they're edematous or not, I know that it's now filling up the piriforms pretty much 100%. It's on the verge of overflowing into their laryngeal vestibule space, right? And so we might be putting them at a little bit of a disadvantage if then like a week later or like a month later or maybe 3 months after radiation therapy, they're a lot less edematous. It might be the same amount of residue that's there, but it's only a 30% rating because there's a lot less filling because there's a lot more space. And I think that has benefits and limitations, right? I think the benefit is functionally, if I'm hearing 30%, now I'm like, it's not really on the verge of overflowing to the vestibule, but it's not accounting for the fact that their efficiency, their bolus clearance is probably the exact same. And so we are missing out on that. And I think it gets us to this idea of how we can talk about residue. And we can talk about residue in two different ways. We can talk about it in terms of kind of an anatomically defined scale, which is what we're doing now. The other way that you can talk about it, which you can't really do with FEES, but you can do with fluoro, is talking about bolus clearance. So of the amount of stuff that went into the pharynx, how much of it cleared through the UES? And that has nothing to do with anatomy now. And I think they provide important but like complementary ways of thinking about swallowing efficiency. I think the same holds true for airway invasion as well. So I think it's everything has a benefit and limitation, and it's one perspective of looking at it. And certainly anatomy is, there's limitations there, but I think there's also benefits.
Great, thank you. I think we've got time probably for a couple more. Somebody's asked about just secretion rating as not part of the VASES framework.
Yeah, I love secretions rating. Honestly, we didn't think about it that much because in our patients, we weren't seeing lots of secretions. But now where I'm working clinically, we include secretion ratings, and we use the VASES framework to think about our anatomic boundaries and think about like percent filling. So we actually use, this is a study idea, I guess, but we use the New Zealand severity secretion scale. And when thinking about like percentage of hypopharynx filled, we use kind of the way of thinking about VASES in terms of percentages and how we're defining the piriforms. And so it's guiding how we are actually doing our secretion ratings. It just wasn't a part of VASES, but I think you could apply the framework because otherwise that's not in detail anyway in those scales as well. So it's either don't be specific or use something and it might be off in future research, but yeah.
Great, thank you. And I just wondered, in terms of using VASES, who else is kind of using it? I don't know if anybody, do you know kind of what other institutions are using it?
I know that I've given lots of in-services on this. So I know there's been lots of interest. I don't know how people are integrating it into like their report writing. I know people have reached out saying that they are using my Excel spreadsheets and my templates and stuff like that. I believe, do you all have TIMS in Europe? Like the TIMS like video archiving thing. Okay, it like pairs a lot with
hit and
video
miss.
fluoroscopy. Pardon?
I think it's hit and miss whether people have it or not.
Okay, yeah. So there's other systems that are actually I'm like not attached to this at all, but that are integrating VASES into like this. So Tim's has like MBS IMP like cards. They call them assessment cards in them. They have like now I guess like maybe they have aspect cards or something, and they're creating VASES cards, I guess, because they've apparently heard from others that they should have VASES. I don't know. So I have a feeling people are using it, but I don't know if it's more from like a scale standpoint or it's from like a, this is just how we look at fees and how we're interpreting fees. It's probably a mix.
Cool, great, thank you. And we'll just have time for one more if that's okay. So someone's posted in the chat interested in how base of tongue and posterior pharyngeal wall residue is being visualized and judged as piriform or molecular residue. Would that not lead to a different understanding of swallowing physiology and management?
Yeah, I mean, I think understanding of swallowing physiology is a little hit or miss again. So I think in terms of base of tongue, I think most people would consider that within the oral pharynx. In fact, by most like anatomic books, that's actually the region of the oral pharynx, and it's how we separate the two. In terms of the pharyngeal wall, I think it can be challenging to figure out like where exactly does, especially in the posterior pharyngeal wall aspect, like you were saying, and maybe the kind of the lateral, where exactly is that line for the oropharynx and hypopharynx. And again, we're using our perception, and probably like our reliability with our colleagues and even our reliability with ourselves might change some, but the idea is that we are trying to conceptualize the thing that it's wrapping around. So there's reliability issues there, and it's not perfect, but we should be kind of conceptualizing it wrapping around, and like anything above that is the oropharynx and everything below it is the hypopharynx. So, and it's kind of going back, when you look at the recording, going back to that kind of side by side of the fees and the flora, where it kind of show the different anatomic boundaries in different colors. I think it's thinking about it in relation to that.
Thank you, James. That was a brilliant presentation. I'm sure everyone will agree. For a Monday morning, I think everyone's brain cells are firing. So I really appreciate you taking the time to come and speak to us today. Of course, excellent presentation. The question hasn't been asked in the chat, but I can guarantee Amy and I are going to receive a lot of emails asking for this. Will you be sharing your presentation with us, please?
Yeah, I can do that. I can definitely do that.
Thank you. I'm doing it in advance of the emails that will now start coming in. Probably already have.
Just email me and I'll reply to the email with it.
Thank you very much. That's great. We will. Thank you so much for your time. Can I ask you to stop sharing your screen, please? Would that be okay?
Oh, was it? Yep. Sorry about that.
No, absolutely fine. Not a problem at all. So we've got about 15 minutes left. And I think it would just be good, and I know this is a virtual forum, so it's always difficult to have rich discussion on a virtual forum. But I'm going to ask some generic questions that have been coming into the CEN recently, and I think it would be really good if we can try and get some active participation in them. So the first one I'm going to ask is a video fluoroscopy question. James, please feel free to participate. If other people would like to put their cameras on, they're more than welcome. How do we, as a speech therapy community, assess for fatigue during video fluoroscopy assessments, including liquid wash, and what do you screen specifically? And for those who use the MBS IMP, how do you do this within the protocol? So how are we all assessing fatigue on a daily basis? If we could do a hands up kind of thing. I mean, the discussion hasn't quite started, but if we could do a hands up just so we're not all joining at once, that'd be great. Going well, guys? Going well. So let me ask a more specific question around fatigue. Do people do things off camera? If they do things off camera, do they have a set amount that they give a patient off camera? Is it a certain bolus type? Eileen, thank God for saving the day. I'm going to let you come in first.
Caroline popped her hand up really early as well.
Sorry.
So
I do apologise. Caroline, if you'd like to go first.
Hi there. I tend to think about what kind of fatigue I'm expecting to see in my patients. So for a patient with a neuromuscular condition, I'd probably be thinking about mealtime fatigue over a whole meal rather than very rapid fatigue, in which case I'd probably think about the timing of my assessment. So if I was bringing someone in for an outpatient clinic, I might ask them to bring something and eat it before the VF. So we're actually looking at their swallow in a fatigued state rather than hoping that we might fatigue them in the space of a few minutes, which is probably unrealistic. Or if I was doing a video fluoroscopy potentially on a myasthenic patient and I wanted to look at their velopalatal movement, I might them to do lots of talking beforehand and then maybe do a little bit of VF in speech to look at VP movement as well. But I tend to do beforehand. We also use the MBS-IMP at the National Hospital for Neurology and Neurosurgery for the question about going and using fluid washes. I think it's a protocol and it's only that. We won't use it blindly, and if we want to do a fluid wash, we just go off protocol and do that to see what's happening in real terms to get the best clinical benefit for our patients, because 99% of our VFs are clinical rather than research, so we can mess around with protocols and do what we want within our own clinical judgment. I'll hand it over to some of the other hands.
Thank you. And Eileen, if you want to go next.
You've already mentioned the point. I was just going to say off camera, fatigue trials with larger amounts of bolus if we're considering to recommend full oral intake to see how the patient tolerates that.
Amy, anything to add to our brilliant contribution so far? You're on mute, my love.
I think Caroline said it already. I think it comes back to your case history and knowing what question you're going in with into the fees of the VF, and you're taking that lead from the patient, whether they're saying what tends to be at the end of a meal, or it's intermittent, or if it's a part of the disease process. I often, will take that on and do the timing of the clinic, get them to down a whole drink, or sometimes finish the biscuit or a sandwich, and then just view the last one. And I do find it is quite good at capturing, and fatigue does show up. If you've got that kind of feeling that fatigue's an issue, I think you can create a fatigue effect within the clinic. So well said, Caroline.
Thank you. And James.
Yeah, I think fatigue is a really interesting concept because a lot of it is there's cognitive influence associated with it. And so I think that's something that's really important if we're thinking about monitoring fatigue is to ask the patient about their perceived exertion and their perceived level of fatigue, to know that we're actually testing fatigue, right? So we can give someone, a bagel or something that's is seemingly taxing, but I think an important way to verify that we actually have been looking at the effects of fatigue is to ask the patient their perception. I don't know the best scale to look at that. There's certainly scales like the Omni scale, rating of perceived exertion. But I know Danielle Braitz, who Dr. Braitz now, that was a lot of her PhD work with Dr. Malfenter, and so she might be someone good to look up some of her research in terms of fatigue. I don't know if it's all out or if she's getting ready to publish it, but nonetheless, I would probably incorporate some sort of patient question if we are as a way to understand the validity of our assessment, did we actually look at fatigue or not?
I think that's an excellent point. I think there is something about a good case history, and I think that's going to be the answer to a lot of the questions we're about to ask. It depends whether we're looking at a neurology caseload, we're looking at a critical care caseload, care of the elderly patient, whatever it might be. I think it's about that robust clinical information at the beginning, isn't it? And then you'll know that feeds into your assessment. It's never a straightforward answer in speech therapy, but so our next question is to do with low frame rates. So one of our CEN delegates has asked, one team has a machine that only captures video fluoroscopy images at 4 frames per second. RCSLT recommendation is 15. MBS is 30 frames per second. Can anyone suggest any mitigations that the team could use to get around this? Do they put a disclaimer on the report, or are there any other experiences that our CEN community has had working with slower frame rates? I personally have had no experience of 4 frames per minute, 4 frames, and that slow rate. I would not be able to advise on that personally. I don't know if anyone else has had any experience. I will take that as a no. Amy, do you want to go?
Oh, not that low, but I have had reduced rates, and we've just put the case forward when you're doing the business case for VF that, you know, what the research suggests, what the evidence is, and put in for the best clinic. So we have had those meetings with radiologists and radiographers to make sure the clinic is as useful as it can be. So we have upped the rate before and compared it with like chest x-rays and safety levels and things like that, and they've all come around. So maybe that's the way to go.
I think what this question isn't highlighting is that a restriction of the equipment?
Yeah.
And if it is a restriction of the equipment, is there other equipment that could be used? That would be my first. We need more details. Once again, it's not a straightforward question, is it? Has anyone got anything else they'd like to comment on? Sophie? Sophie, if you're speaking, we can't hear you. Oh. Okay. The hands are down. James, do you want to come in?
I think that if you're limited by the equipment, I think what's might be important to keep in mind is, again, trying to keep in mind the validity of our assessment. So the measures that you're using when using equipment that's 15, ideally 30 frames per second, are likely going to be different measures than you can, you're probably not going to use the same measures than if you're looking at something that's 4 frames per second. So I would think if it's like 4 frames per second, I don't know, but I would think things like pharyngeal residue, you might be able to judge after the swallow because that's not so much timing dependent. You know, aspiration and penetration, we know that theoretically can change when going from 30 to 15 frames per second. So I would assume it'd be maybe a lot more tentative. Certainly assessment of swallowing physiology when that's these things are occurring in certainly less than a quarter of a second. I probably wouldn't comment too much on physiology. I'd probably limit my interpretation to residue in the oral cavity, pharynx, and esophagus, just to maintain validity and not trying to, because then if you start to comment on things like aspiration and it's missed, we don't know if it's missed because they didn't do it or because it's our assessment. So I'd probably try to stick with things that are valid and reliable at 4 frames per second. And the only thing I can think of would be pharyngeal residue or oral residue.
Thank you, James. Really good contribution. I'm going to ask an MBS IMP question now for the people doing it. So for those on the call, how many people are using, how are people finding the use of MBS IMP versus other reporting methods? And can they share their experiences? So do we have anyone on the call today who is using it? You know, you rate it for us, let us know what your experience of it is. If one person is trained, are the whole team trained? How does it work within your departments? This is the problem with virtual. Caroline, thank you again. Coming back to NHNN for us. I know you guys use it. Give us your experiences there, please.
So we're very, pardon me, lucky, and most of us who are video fluoroscopy competent in the service are also MBS IMP certified clinicians. I came to the National having done my video fluoroscopy training elsewhere, and initially I found it very challenging, as I felt I almost had to unlearn things about my video fluoroscopy interpreting that I'd felt to be true and correct before, but are slightly different on the MBS IMP. And anyone knows, you know, you can't teach an old dog new tricks. I think it's harder to learn something the second time round than it is just learning it as you start your VF training. However, I absolutely adore it. I think, of course, it's got its limitations. And when it's a number and you think, oh, I still want there to be almost a half, but it's there for a reason. And what I really, really like about it is how much it breaks down for the laryngeal vestibular closure. I've never thought about it in so much detail as the early closure and the late closure and the other bits that go in between. And I think that's really honed what I do in terms of any treatment or therapy management, thinking about the exact timing of where airway penetration or aspiration can happen. I also think for the oral phase, it's definitely made me think about the oral phase much more in depth than I ever would have done beforehand. And I really like, a bit similar to James when you were talking earlier about us having a standardised language and terminology that we're using. I think we still haven't even agreed how to spell the piriforms, and having a more standardised language where we're talking about the laryngeal surface of the epiglottis rather than the underside, or is it the laryngeal vestibule, or is it in the hypopharynx, I think is really helpful. So I would certainly recommend it. I do think you have to be video fluoroscopy competent separate to MBSI competent, and being MBSI competent does not automatically make you video fluoroscopy competent, because of course it doesn't do your analysis. So you still have to bring together all of those numbers at the end to make it into a meaningful report for your patient and their treatment management. But I really rate it, and I like it very much. So I'm glad I'm here and have the opportunity to use it regularly.
Thank you, Caroline. That's some valuable feedback. And Sally, what are your experiences with MBS imp?
Hello, I just wanted to apologise. I've been having connection issues. I had a comment on one of the previous questions as well, so I'm going to be annoying and jump in. But first of all, I put my hand up and then started listening to Caroline, and basically everything Caroline said is what I would say. One of the things to just bring out is, so where we work, I am fully trained. No one else has done all the training, but we've done a lot of in-house, in-service teaching. The way we use it is we still write a prose report, but we agree, there's two of us that analyse all the images for a patient, and we do inter-rater reliability between the two of us for every single component on the MBS-IMP, and that helps us write our report. And we use a lot of the terms and the ratings based on the MBS-IMP. Just following on from what Caroline said about it doesn't make you VF competent, and that is 100% what I would agree with. And something I've learnt more about is that we have quite a few people who join the team who say, I've done MBS-IMP, so I can do video fluoroscopy, and it turns out that the story of the swallow isn't there. So they've done that training, they can look at images and rate them, but actually what's happening, cause and effect, how am I going to treat this well, doesn't come through with that. And then just because of jumping in late, the question about fatigue, this is more just a comment rather than any advice, but it's just to make sure that people remember that fatigue is complex, and it is the psychological fatigue as well as we've got to remember physiological fatigue. And what we're not necessarily going to pick up is what we're seeing. And physiological fatigue, where you're talking about how the muscles are firing, and whether there is endurance in the actual muscle capacity, we probably won't pick up with a video fluoroscopy. And there's so many things that can lead to a patient performing differently, and it's difficult to tease out. So yes, that case study question, and then also just inferring rather than diagnosing fatigue on video fluoroscopy, because we can't do it because it's not a physiological test. I'll stop talking now, but thank you. It's all been brilliant what I have heard. I'm going to watch the recording back because of what I've missed.
Thank you, Sally. Always a pleasure when you join us. And Suzanne, please.
Hi, yes, can you hear me?
You can.
Yeah. Yeah, we are lucky that all our 4 video therapists have had the funding to do the MBS-IMP training, but we were all doing video fluoroscopy before that as well. And I do agree that I do think that that's important, that you can see beyond the MBS-IMP. We don't follow the protocol rigidly, so we don't do all the trials as it's stated there, so we still kind of choose what we think is most appropriate for the patient, and we do a mixture of prose report, but we copy and paste the table from the quick print view into our reports. So we've got all the scores for the MBS-IMP there, but we also write the story in prose form as well.
Brilliant, great feedback. Thank you, Suzanne. And Kate, please.
Just to add, so we are a community service and we have somebody MBSM trained in each clinic, but we've got the scoring integrated onto System 1, and it is available for anybody else using System 1 to download as a template, and then that auto fills into the report, which we found really speeds up our report writing, and then an easy template to view when you look back for repeats.
Thank you, Kate. It's always good to get feedback from various clinics as well, inpatient versus outpatients, and how we're all doing the same thing. So really valuable contribution. Thank you. Anyone else wants to ask any more or contribute any more to that subject matter? No? Well, I'm going to suggest we stop there. But oh, wait a minute, hold the phone. We've got a question in the chat. Multiple things happening at once. How do we get a copy of the S1 template, please?
On your System 1, there's a resource library at the top, so it often has to go through IT, but it's just downloadable. You can search for it and see. So that we also use it for therapy outcome measures, and again, they're downloadable from there.
Brilliant. Thanks, Kate, for answering that. I've got some live question and answering going whilst I'm trying to just wrap everything up. If there is no other questions that are hankering to come out right now for the topics we've had, I'm aware of the time. It's a Monday. It's a busy day to do a bit of CPD, but I'm glad for the people who could join us. I promise the next day will be in person. We can't have conversations like this and not be in person, because I think we get much richer conversation. James, I would like to thank you again for being an excellent keynote speaker today. Your contribution was just phenomenal. I think you've blown everyone's socks off on a Monday morning, so thank you very much, even though you're on your holidays, so I appreciate it even more. And if people could complete the survey monkey in the chat box, that would be most appreciated. We are a CEN that is currently has the smallest committee in the universe because everybody is traveling the world. So we really, basically me and Amy just trying to think of ideas at the moment, and when Orna and Rich can join us, we love it. But yeah, so we really need your feedback and we need your contributions. So yeah, we'll see you all then next time. If there's nothing else, I'm going to let you all go. Have lovely Mondays. Yeah, nice to see you all, guys. Thank you.
Bye-bye.